Look at this quote. It says that we are surrounded by data but are starved for insights. This is indeed true, right? So the purpose of conducting this recall discussion, exam discussion sessions here is not to give you some data about this was the question asked and these were the options and all those things, but because that is something which is already there out there in the domain. You have multiple resources which have already done that quite early, maybe within 24 hours of conducting the exam. But the purpose with which what we are here is not to give you this data, but to give you important insights about those questions, about those topics, about the concepts which are related to making a diagnosis and diagnosing those conditions, such that you should be able to use those insights into your exam going ahead, right? So it is these insights that we are going to work on more. Another thing is that you'd realize that when I looked at the recently conducted exam, say for example the NEET PG pattern exam, right, I found that there are almost 10 to 15 questions which had some radiology based image within it, and so I would proudly claim that these are my questions, and so I would discuss it. You'll find that I've discussed very few questions in this discussion though. The reason is that at this stage we want to give you the highest possible yield that you put in a very short, concise amount of time. If I decide to discuss all these 15 questions and then every faculty does the same, these discussion sessions would become too long and we don't want that to happen. So you would find that there are few questions that I have discussed here, some questions that I have not discussed, like achalasia cardia, like say pneumoperitoneum, right? Like say for example, there was a case of say intussusception. So all these questions have been discussed by other faculties in their respective subjects so that we have a very concise session here and you get a very high yield out of it. So let us look at the first question which was asked. Look at this question now. This imaging modality shown here is what? Now what is this image? If you watch carefully, right, this is a coronal reconstructed image, right? It is atypical for a radiology image because it is a color map based image. But if you look at the bones appear white, dense, like they appear on CT, but CT never shows these colors, which means that there is a color map which is superimposed over this particular image. This is a classic example of a hybrid or a fusion imaging technique where, right, an anatomic imaging modality like CT is combined with a metabolic or a functional imaging modality like PET. So what is this? This is actually a PET CT, where CT is giving you the anatomic information as to where the brain is, where the humerus is, where the lungs are, where the liver is, where the spleen is, right, where the pelvic bones are and where are the muscles, whereas PET is giving you the functional information about the metabolic status at that particular site. So this is what? This is a fusion imaging technique, right, called as PET CT. Now remember, PET scan is an absolute favorite of your examiners. Lots of questions have been asked on PET scan. So in this NEET pattern exam, this was the question which was asked. There was another question which was also related to a topic on PET scan, and this was about the Warburg effect. So I'm going to take the liberty of discussing it here. True regarding Warburg effect is what? So let us quickly look at some basics of PET scan and then we'll solve both of these questions. Don't worry. Okay. So let us look at the PET scan in an animated way. So look at PET scan. What is PET scan? PET scan stands for positron emission tomography. Tomography means cross-sectional modality. And in PET scan, the radionuclide which is used is a positron emitting radionuclide. What is the most common radionuclide used in PET scan? It is 18-FDG. Yes, we are going to discuss that. So a positron emitting radionuclide is used for a tomographic technique, that is PET scan. Now, most important application of PET scan is cancer imaging. So right from primary diagnosis of cancer to staging of cancer to detect metastasis, a patient is on treatment to assess the response to treatment, and the patient has completed the treatment to look for recurrence of cancer. So for all these things, PET scan is used. Everything related to cancer imaging, which scan is done now? It is the PET scan. Now in PET scan, the radioisotope that we use is a positron emitting radioisotope. radionuclide. What is that? It is 18-fluorodeoxyglucose. 18-FDG is the most common radioisotope or radionuclide which is used in PET scan, and it is after all glucose. Right? Look at the name, it is glucose. So this is the structure of glucose. The radioactive part is 18F or 18-fluorine. So what it does is that one hydroxyl group is displaced by fluorine, and that is how 18-fluorodeoxyglucose is produced, right? Now, if you look at a normal cell with a baseline glucose requirement, there are only 2 GLUT transporters because it has very little glucose requirement. Cancer cell has to divide rapidly, right? And because of this rapid cell division, it has a very high glucose requirement. So compared to a normal cell, the number of GLUT transporters is very high. Specifically on the surface of a cancer cell, it is GLUT type 1, right? Glucose transporter, which is abundantly overexpressed. Now in this patient now with a normal cell and a cancer cell, if in the bloodstream, I have injected 18-FDG. FDG is what? Glucose. Glucose transporters are more on cancer cell. So where will all the FDG go? Most of the FDG that I have injected therefore will go inside the cancer cell, isn't it? Because of the overexpression of the glucose transporters. Not just this. Every step in the utilization of glucose is also overexpressed. So what is the first step in glucose metabolism? Glycolysis. So hexokinase acts on glucose, produces 6p glucose, glucose 6-phosphate. Similarly, this hexokinase in the hurry and flurry also jumps on 18-FDG. It phosphorylates it and creates 6p FDG, and it is at this point that it realizes, oh my god, I have been tricked. This is not glucose, this is FDG, but by this time it has already 6-phosphorylated it. That is how, remember my friends, that this FDG becomes thus trapped within the cancer cell, right? So it becomes trapped within the cancer cell. That is the reason why, right, FDG is the most common isotope which is used in PET scan, which is used for cancer imaging, because this 6p FDG is taken up and it gets trapped within the cancer cell. Now let us look at Warburg effect. Now, how does a normal cell use glucose? In the presence of oxygen, right, there will be glycolysis, Krebs cycle and oxidative phosphorylation, 36 ATP will be produced. In the absence of oxygen, only glycolysis will happen, so only 2 ATPs will be produced. Now let us see what happens with cancer cell. Suppose there is glucose which is there and oxygen is also available. See, so when oxygen is present, this glucose will be taken up by the cancer cell. Glycolysis will happen. And what is the end product of glycolysis? End product of glycolysis is pyruvate, right? This pyruvate will then go into the TCA cycle, Krebs cycle, and oxidative phosphorylation. Correct? And ATP will be produced because oxygen is present. So TCA cycle, oxidative phosphorylation will take place. Right? The atypical, phenomenon that happens in a cancer cell is that in spite of oxygen being present in a cancer cell, surprisingly, TCA cycle and oxidative phosphorylation is inhibited or inactivated. Therefore, in spite of oxygen being present, they cannot happen. TCA, oxidative phosphorylation cannot happen. So pyruvate is converted into lactate. How many ATPs are produced? Only 2 ATPs. This is given a name. This phenomenon is called aerobic glycolysis. Normally, glycolysis is anaerobic glycolysis. But here, even in the presence of oxygen, right, because TCA cycle oxidative phosphorylation is inactivated, glucose is utilized only by glycolysis. This is aerobic glycolysis, an inefficient mechanism, right, that the cell uses. But why? Remember, cancer cell has to divide rapidly. If it has to divide rapidly, isn't it? It will have to generate some cell cycle, cell division intermediate metabolites. So this pyruvate and lactate, which is thus excessively produced in a cancer cell, is shunted to produce cells division process intermediates. And this is what gives the cancer cell a distinct survival advantage. So this is what gives the cancer cell a distinct survival advantage in terms of the excessive synthesis of these cell division process intermediates. But do you realize that this is a very inefficient way of utilizing glucose? Cancer cell requires more amount of glucose because it has to divide. But at the same time, it is using this glucose in a very inefficient manner. Irrespective of O2 availability, because TCA cycle oxidative phosphorylation is inhibited, from one glucose, only 2 ATPs are produced. So cancer cells use an inefficient process for glucose metabolism. This is what is called as Warburg effect, right? This is what makes the cancer cell even more and more and more glucose hungry. Remember, on one hand, it is going to take up more glucose. It needs more ATP for cell division, but it cannot use it well. It uses an inefficient process, and therefore cancer cell, remember, is an extremely, extremely hungry, glucose hungry cell, and therefore this further accentuates our cause. And what is that? 18-fluorodeoxyglucose is used very commonly, or most commonly, in PET scan, because most of it is now going to go into the cancer cell. Now, once it goes into the cancer cell, 18-FDG is going to emit what? It is going to emit a positron emission tomography, isn't it? So this positron is like a twin brother of an electron. It is exactly identical to an electron, except that it has opposite charges. So just imagine they are like two twin brothers who are separated from one another in the Kumbh Ka Mela. So when they meet after such a long amount of time, right, they simply embrace each other, they collide with each other, and when they collide with each other, annihilation occurs. Annihilation means complete destruction. So both positron and electron, they are destroyed, completely destroyed. Matter is destroyed. It is converted into energy. Energy in the form of what? Energy in the form of gamma ray photons. 2 gamma ray photons are emitted. Each has a strength of around 511 kiloelectron volts, and they travel in 180-degree opposite direction. So what is annihilation reaction? Inside a cell, a positron is emitted by FDG. This positron collides with a tissue electron. Both of them are annihilated or destroyed, right? Matter is converted into energy, and this energy comes out as gamma ray photons. So this is all you need to know about PET scan. So see, true regarding Warburg effect is what? Tumor cells use less glucose is not true. They in fact need more glucose because they have to divide. So there are more GLUT transporters. All the enzymes used in glucose metabolism are overexpressed. They don't use less glucose. More ATP is generated? No. Less ATP is generated. Why? Because TCA cycle and oxidative phosphorylation are inactivated. So even if oxygen is present, it cannot happen, and therefore instead of 36, only 2 ATPs are produced. So less ATPs are produced. Cell gets metabolites for cellular components is correct. What is the concept behind the purpose of Warburg effect? Why has nature created Warburg effect in a cancer cell? Is because this pyruvate and lactate, which is excessively produced, therefore is shunted off to produce the cell division process intermediates. Helps tumor cells to be immortal? No, Warburg effect does not help the tumor cell to be immortal. So the answer is cells get metabolites for, or cell gets metabolites for cellular components. So this is the answer to this particular question. So this is just based on Warburg effect. Now that we have seen, we've jumped into this by seeing a color image. Let us look at some imaging techniques which are some colorful imaging modalities. One such, remember that radiologist, in the radiology, wherever color is used, it is used not to make a particular image look beautiful, but only when the color adds to some specific information, either the metabolic status or the direction of blood flow, or the functional degree of underlying functional center, say in the brain. So this color always gives us some additional information. Let us look at an example. So this is an example of color Doppler. Now in color Doppler, when you see this red and blue color, remember the red color in the portal vein means that the blood flow is occurring towards the liver, into the liver, or towards the probe, right? It is a subjective technique. Blood flow can be seen, but it cannot be measured. This red and blue, remember, is red usually means towards the probe, blue away means away from the probe. But remember that this is actually subjective. So this can actually be reversed. If I press the invert button, the directions can completely get inverted. See, the color scale on the top left has also inverted. So this is called color Doppler. Well, the color gives me the direction of blood flow depending upon the color scale that I have used. There is another technique which is used in Doppler, which also uses some colors, which instead of using colors, so this has a very low sensitivity, color Doppler, it can miss low velocity blood flows. In order to overcome this, power Doppler is used. What is power Doppler? Look at the color scale. It is a single color scale, right? No two colors. So it does not tell you about direction, but it tells us, though it is subjective, right? A single color is used, so direction is not shown, but is extremely highly sensitive, right? So it can detect even the minutest amount of flow, or even low velocity flow can be detected by using power Doppler. So advantage is high sensitivity, even low velocity flow can be detected. So we have studied color Doppler, we have studied power Doppler, right? Color Doppler, power Doppler, both, tell us about the blood flow, right? Now, when you can, however, we can measure the blood flow, right? You can see the color Doppler on the top, and below I am actually creating a real-time tracing here, right, of that blood flow. So this is what is called as the spectral Doppler, and this spectral Doppler is not a subjective technique but an objective technique, because I can actually measure the blood flow, I can measure the peak systolic velocity, end diastolic velocity, I can use the, you can see the flow pattern inside the blood vessel. Now another USG based color map is called USG elastography. Now this elastography, as the name suggests, it determines the elasticity or the hardness of a particular lesion. Now see, it is used mainly in breast to characterize breast lesions, liver lesions, thyroid lesions. Now see, in breast cancer, we all know that breast cancer lesions are very serous lesions, serous or hard lesions, right? And therefore, their hardness is extremely high. This hardness is plotted on a color scale, and depending upon the hardness, the different color is used, right? And that is how we can be able to distinguish between a soft lesion like a cyst or a fibroadenoma versus a breast cancer. Okay, strain elastography and shear wave elastographies are advanced applications of elastography. In CT and MR, we use certain techniques which are called perfusion techniques. Perfusion means capillary level blood flow. See, angiography, CT angiography, MR angiography shows us the blood vessels. But can we measure the blood flow within it? That can be done by using perfusion technique, where contrast is injected and the machine measures how this contrast is reaching the organ, say the brain, and then it is plotted by means of a color map. So there is a time to peak, there is a mean transit time, there is a cerebral blood volume, and there is a cerebral blood flow. Of the cerebral blood flow, cerebral blood volume are most important ones. It is plotted as a color map that you can see here. So the blue area usually represents a low perfusion or low blood flow. So that particular area is probably infarcted. That is what we see here. Now an image very similar to CT perfusion is called MR perfusion. Again, based on MRI contrast which is injected, color maps are plotted. The perfusion is, information is given as cerebral blood flow, cerebral blood volume, mean transit time, and Tmax, that is time to peak. And based on these parameters, the diagnosis can be made. Another image where you'll see predominantly an MRI image, but focal color superimposition on it at specific centers of the brain when they are working, right? This is what is called as functional MRI or BOLD. What is BOLD? It is blood oxygen level dependent imaging. So this can actually determine the status of the various functional status. So which means that when I'm speaking, right, my Broca's area is getting active. So this Broca's area, right, is going to receive a lot of oxyhemoglobin. There is going to be less deoxyhemoglobin. So depending upon this, deoxyhemoglobin has paramagnetic properties. So by determining the concentration of deoxyhemoglobin in various functional centers, right, the machine will be able to detect that my Broca's area right now, because I am speaking, right, is extremely active. If you're listening to this video, so your Wernicke's area is extremely active. Comprehension, you're trying to understand it. So therefore, if I do a functional MRI, BOLD MRI of your brain right now, it is your Wernicke's area which will show excessive oxyhemoglobin, decreased deoxyhemoglobin, and therefore it will show as bright signal at that particular point. So that is how various functional status or functional centers within the brain can be highlighted using BOLD MRI or functional MRI. All these radionuclide scans, especially for an example, DMSA scan. So DMSA scan, do you remember? It is used for structural and anatomical information related to the kidneys. Why? Because it gets concentrated within the renal cortex, and therefore any renal structural abnormality will be able to detect. So here you can see that the left kidney is located well down within the pelvis rather the right kidney is at its normal position. Left kidney is located deep down. So this is anatomic information we are getting. This also appears as a crude color map. Okay, so these were some color imaging modalities. We jumped into this discussion with PET CT. That was the answer in that particular question. Now see here, a patient presents to the casualty following a road traffic accident. Blood pressure is 90/60, hypotension. Respiratory rate is 40, which is elevated. Pulse is 120, which is elevated. X-ray is shown. What is the next step in the management? Now, if you see here, in this particular radiograph, if you see, what is the finding? So here, what we are able to see basically is that there is a sharp line along the surface of the lung. Outside the lung, this is the pleural cavity, which is appearing lucent or black with absent vascular markings, right? Either it is actually it is appearing excessively black, so that is called hyperlucent with absent vascular markings. This line on the lung surface is what is called as the visceral pleural line, right? There's no significant mediastinal shift, or the diaphragm is also not being pushed down. So the diagnosis I can say is that the pleural cavity is appearing excessively black because there is air within the pleural cavity. Air within the pleural cavity is what? Air within the pleural cavity is pneumothorax, right? So this is a case of pneumothorax. Now remember that when we try to distinguish between plain pneumothorax and tension pneumothorax, some of the findings would be similar. So findings would be similar in terms of the visceral pleural line. Air within the pleural cavity will appear black. But in tension pneumothorax, there will be mass effect, which will be prominently seen. So this excessive air within the pleura will compress, will push the mediastinum to the opposite side, will push the diaphragm down. Because the pressure is high, it will compress the SVC, IVC, venous return will be blocked, right? Cardiac output will fall and the patient might even die. So therefore, it is very important to specifically look for signs of mass effect to diagnose tension pneumothorax. Now look at this another image. See here in another image, here you can see the visceral pleural line. You can see the hyperlucency with absent vascular markings. But see the significant mediastinal shift. The diaphragm is pushed down, so the costophrenic angle sulcus appears excessively deep, right? So this is what is called as the deep sulcus sign, and there is slight hyperexpansion of the rib cage, which is also noted because of that pressure caused by the excessive air in the pleural cavity. So this diagnosis in this case, because you see mass effect, because you see deep sulcus sign, because you see overexpansion of rib cage, I would say that this particular patient diagnosis is tension pneumothorax. Now in tension pneumothorax, what is very commonly asked by your examiners is, what is the treatment? Because it is an emergency, the intrapleural pressure is at very high pressure, the intrapleural air is at very high pressure. The first step in the management of tension pneumothorax is called needle thoracotomy. That is, you put a needle in the thorax. If you put a needle in the thorax, right, what is going to happen? The intrapleural pressure is very high. So air will first come out along the pressure gradient, right, out of the thorax through that needle until the time that the pressure becomes zero, that is equal to the atmospheric pressure. Then the air will stop coming out because there is no pressure gradient now. So the tension component is relieved. What remains is plain pneumothorax. And what is the treatment of plain pneumothorax? It is an intercostal drain insertion. Where is this needle to be inserted? In adults, this wide bore needle is to be inserted in the 5th intercostal space in the mid-axillary line. Whereas in children, this needle is to be inserted in the 2nd intercostal space in the mid-clavicular line. Okay, so this is what is the management of tension pneumothorax. Okay, now look at this particular patient. Here we have seen that this is pneumothorax, there is visceral pleural line, there is hyperlucency, but there is no mediastinal shift. The diaphragm is not pushed down, so there is no signs of mass effect. Because there are no signs of mass effect, diagnosis here is not tension pneumothorax, it is plain pneumothorax. And what is the next step in the management of plain pneumothorax? It is just chest tube insertion. We put in a chest tube, put the distal end under a water seal. So what will happen is that gradually, slowly, this air will get resorbed, right? And what will happen, once this air will get resorbed, the lung will expand and the pneumothorax will completely go away. So therefore, the answer here is chest tube insertion. Okay. If there is mass effect, then the first step would be needle thoracotomy to relieve tension component, followed by chest tube insertion. But here there is no sign of mass effect. This is not tension pneumothorax. This is plain pneumothorax. Okay. Look at the diagnosis. What can you see here? So here what we can see basically is that there is air in the pleural cavity, but there is also fluid in the pleural cavity. So air and fluid both in the pleural cavity, creating a air fluid level, right, is what is called as hydropneumothorax. So this is hydropneumothorax, right? When you see an air fluid level within the pleural cavity. So see on CT, right, this is the air fluid level, and this is all the fluid. So this is hydropneumothorax, how it would appear on a CT. Now, when we look at a normal USG thorax, remember that these are all the chest wall layers. Where the chest wall ends, we see the ribs, and can you see this bright line here? This line is called as the pleural line. Now, at the place where this pleural line is, there is visceral and parietal pleura which are touching each other. Now, normal lung, remember, it is expanding, retracting, inspiration, expiration, and therefore, in a normal patient on B mode, that is this image, right, there is a constant sliding movement which will be seen at the level of this pleural line because the lung is expanding, retracting, right? So now, if you look at this particular video, see here. So here, can you see that sliding movement at the level of the pleural line? See that sliding movement there. So this is what is called as the normal pleural sliding. This is seen normally. But what will happen in pneumothorax? So remember, in a normal case, as you can see here, there is a pleural sliding which is present. Now what will happen in a case of pneumothorax? In case of pneumothorax, right, there will be air in between the visceral and the parietal pleura. This air will not move up and down, that is pneumothorax will not move up and down with inspiration, expiration, and therefore this pleural sliding will be absent. This pleural sliding will be absent. So absence of pleural sliding is a feature of pneumothorax on ultrasound. On M-mode ultrasound, an appearance called as seashore sign is seen normally, where the chest wall layers create the waves. The sand granular appearance is created by the lungs. This is called seashore appearance on M-mode in normal patients. But in pneumothorax, this lung is no longer there because it is pushed inside. There is all air in the pleural cavity. This creates a striped appearance. This is called stratosphere sign or barcode sign. So seashore sign in normal patients, stratosphere sign, barcode sign in pneumothorax. Now normally on B mode images, you see these vertical longitudinal lines. These are called as B lines. These are seen in normal patients. Whereas in pneumothorax, we see horizontal spaced out lines called as A lines. So quickly, let us revise USG findings of pneumothorax. Normally, pleural sliding is seen. In pneumothorax, pleural sliding is absent. Normally, seashore sign is seen on M-mode ultrasound. On M-mode ultrasound in pneumothorax, what we see is not a seashore sign but a stratosphere sign or a barcode sign. Normally we see vertical or longitudinal lines, these are called B lines, right? Whereas in pneumothorax we see horizontal spaced out lines, these are called A lines. So thus coming back to this, right, we saw that there is pneumothorax without any evidence of mass effect. So the answer to this particular question we have already seen is chest tube insertion.